Welcome back to Thrani, I'm Joe B. Today I'll show you how to perform a lumbar flexion and rotation clearing manipulation for patients who have multiple vertebrae stuck in extension, rotation, and side bending to the right, or an ERSR. That's a mouthful. Let's dive in. A lumbar ERSR is when a singular or multiple vertebrae of the lumbar spine gets stuck in extension, rotation, and side bending to the right. When it's multiple vertebrae, it's called a stack ERSR. The cause of this can be due to tightness of the ipsilateral multifidus muscle, likely from a job that requires repetitive extension, side bending, and rotation to the right. Trauma from a motor vehicular accident can also cause it. An ERSR vertebrae can bring about a chronic localized dull aching pain on one side of the low back. There will also be limitation in motion pattern, specifically towards flexion, left side bending, and left rotation. To treat a stacked lumbar ERSR, patient is in supine with hands clasped and placed behind the neck. The therapist is on the side where flexion and rotation motion is limited, this case to the left. The patient's upper torso is passively rotated towards the left where motion is limited to take up the slack and get the patient past mid-range of rotation and up to the limit of the range. The right hand holds the patient's right arm, while the left hand is on the patient's right anterior superior iliac spine, or ASIS, to stabilize. The therapist pulls the trunk towards the limits of the rotational range with the right hand. From there, a quick end range thrust is delivered towards more flexion and rotation, while the ASIS is stabilized. This technique can be done for 1 to 2 reps, and a cavitation or a pop in the spine can be felt. The assessment for ERSR in this animation, we will assume that it is the L5 that is stuck in ERSR. There are 2 types of tests that determine lumbar asymmetry: the seated lumbar flexion test and the seated lumbar extension test. Since your patient is stuck on L5 ERSR, then to make that vertebrae stick out, you need to select the seated lumbar flexion test. Patient is in short sitting position, feet flat on the floor, and arms across the shoulders. The therapist will be behind the patient. The iliac crest will be palpated first by the web space of the therapist's hands. Then the dominant hand thumb will reach across to arrive at the L4 spinous process. From there, the thumb goes down to the next inferior spinous process, which will be L5. Afterwards, the thumbs move 2 finger breadths laterally to arrive at the transverse process, which will be the major landmark to palpate to determine the presence of ERSL or ERSR. The patient is then asked to slouch for lumbar flexion. When doing this assessment, always start by palpating the L5, then go superiorly until you finish all the lumbar vertebrae up to L1. Normal findings are that all the lumbar vertebrae transverse process should move backwards or become more palpable. Abnormal findings to confirm the presence of L5 ERSR is that the right transverse process will become more prominent during seated lumbar flexion, since the L5 left-sided facets are stuck downward and forward. For the exercises, repetitive seated or standing lumbar flexion, left side bending, and left rotation active range of motion can be done for 2 to 3 sets for 10 reps. This can be progressed by adding 15 to 30 second hold times for stretching. So do you want to know when and how to use a lumbar extension clearing manipulation for your patients? If so, then watch this next video. Thank you so much. If you like this video, please like, share, and comment. And for more therapy animations, please subscribe to Thrani.